Thank you. Thanks, Rebecca, for that
Right.
warm welcome.
Right,
And,
slides. Okay.
okay. And thank you for the invitation and everybody for coming today. That's really fantastic. Okay, what have we got? As you can see on the right of the screen, there's a pictograph of from infancy to elderly. So whether you're 2 or 92, the subconscious language structures around which we can influence non-volitional responses that can be helpful to patients suffering pain and other symptoms are actually identical. There's 2 main language structures I'm going to be talking about today. Superficially, the words are different, but the underlying concepts are identical, and they're interdisciplinary, whether you're a surgeon, anaesthetist, psychologist, traditional therapist. There is no more traditional therapy than hypnosis, which has been used for thousands of years and illustrated through the dreamings of indigenous people. Imagery, imagination are the language of the subconscious and can elicit changes in mood, perceptions, behaviours. There's a functional MRI of the brain there, and the top area shows sensory cortex. As an anaesthetist, if I pop a drip in, often anaesthetists will say, sharp scratch coming. And the patients feel something sharp, that's sensory cortex. But they also get a light up, as you see, of the lower image of the anterior cingulate cortex, which links sensory to reticular formation, basal ganglia, the emotional component attached to the sensation. And what tends to happen if we give a negative suggestion, these are called negative suggestions, this is going to hurt, this is going to sting, bee sting coming, whatever, that area of the brain will light up and you'll get an experience of pain and suffering, an emotional component added to the sensory component of sharpness. Now, if you actually just say to the person, we're just positioning the drip to rehydrate you, keep you safe, give you medication to get you comfortable, it doesn't light up, surprisingly, and patients tend not to get that associated suffering attached to the sensation. And we see this in obstetric anaesthetist and paediatric anaesthetist. We see this in classically in labour, where some women will experience a contraction as a signal they're getting closer and closer to seeing and holding their baby and have an absolutely exhilarating, fulfilling experience, while others will find it the most terrifying, painful, excruciating experience possible. And without appreciating the meaning behind the contraction. So you can imagine, therefore, that the anterior cingulate cortex will be lighting up in those women approaching labour, terrified of the next contraction, and those women approaching labour looking forward to the arrival of their baby are very different perceptual experiences. One of the first studies in recent times to look at this is in the upper right-hand corner there, sorry, left to you, where it says, can words hurt? Elvira Lang was an associate professor of radiology at Harvard, and she actually looked at, she was videoing patients having painful procedures like renal biopsy. And if they were told this is going to hurt and be brave or don't worry, things like that, anxiety and pain increased. They all had fentanyl PCAs. And, but if they weren't given negative suggestions, anxiety scores decreased, pain scores decreased. I think that's all I'm going to say about that. So this picture here is a painting of Fields. It's called The Doctor. It was painted a couple of 100 years ago. And it really it really emphasized the importance of this subconscious communication. Just by being there, just by talking to the patient, can be incredibly therapeutic without all the sophistication of modern day medicine. And I'm just going to be talking about hypnosis as a medium through which we can give suggestions, pain, something called the Great Laws of Communication, which is the language structures I was talking about, and something called nocebo, which is the evil twin of placebo, which you may have heard of. Nocebo is less commonly appreciated, and it really is all the side effects that are non-pharmacological, that we consider non-biological side effects of an intervention. So I'm going to talk a bit about definitions, about these language structures. GREAT stands for greeting, rapport building, expectations, addressing concerns, and tacit agreement. It really is a structure for any interaction, any interpersonal interaction, any therapist interaction. And laws is about building rapport and eliciting subconscious responses. And it involves listening, acceptance, utilization, reframing, and suggestion. And I'll be going through how we integrate that into our everyday language. So, nocebo, otherwise known as negative suggestions, these are the adverse effects of our interventions in healthcare, how we can maybe reframe them into something that isn't harming patients in the way we communicate with them. And then suggestion is communication, be it verbal or non-verbal, that can elicit our subconscious non-volitional response in the person we're interacting with. So, for example, in my field, if we hand someone a sick bowl and they're not feeling sick, there'll be a proportion of patients that will start feeling nauseous, and some will even vomit because they're receiving this non-verbal cue to vomit into the sick bowl, even though they hadn't been sick before. And similarly with pain scores, if you ask someone a pain score and they're not in pain, they're trying to work out how much pain they've got. And just by asking them the question increases their pain, or actually introduces pain when there previously wasn't any. I'm going to talk a bit about therapeutic mumbling. This may sound a bit strange, but what you can do here is, and I'll explain this a little bit more later on, is when we breathe out, the diaphragm and the intercostals are at their most relaxed state, and we call the volume in the lungs functional residual capacity. So as you breathe out to functional residual capacity, the chest wall's maximally relaxed. So if you say to someone, as you breathe out, you can notice yourself relaxing, and each time you breathe out, you can find yourself relaxing even more, they will subconsciously focus on the chest wall because you're talking about breathing, and you've given them the suggestion that they're going to relax as they breathe out. And what happens in the brain is they get a subconscious yes in the brain, noticing subconsciously they've got chest wall relaxation. If you then say, well done, as they breathe out, that's good. The next time they breathe out, aha, yeah, there you go. That's it. By the time they've got 5 of these subconscious yeses, they get a non-volitional subconscious relaxation response to the rest of the body. So we're developing what's called a series of yes sets. You're talking about what we call physiological truisms. It's very hard to deny you're getting a relaxation of the chest wall when the chest wall's relaxing. And with these physiological truisms, a series of yeses, it elicits the non-volitional subconscious response to your suggestion that you can relax as you breathe out. Okay, so we're talking about one of the really important things about interacting with patients and clients to build rapport is just asking permission at a very early stage for something really simple. And as you get asked more and more permissions generating yeses, patients suddenly find they can do all sorts of complex things that they couldn't do if you asked them to do a complex thing right at the beginning. So, for example, if someone says to me, they've got their name says Mary on the notes, the medical notes, and I say, is your name Mary? I introduce myself, is your name Mary? And they say, no, I'm known as Bernadette. And I say, okay, that's fine. Is it okay if I call you Bernadette then? Yes. Would it be okay to come into the room now so we can talk about how you might be able to feel more comfortable? Yes. Is it okay to sit down as comfortably as you can for just now? Yes. Okay. So asking permission at each stage, generating yeses can lead to the eliciting of these non-volitional changes in perception. It also builds rapport. Sometimes when I ask patients their name, they say things like, "Oh, just call me whatever you like." And to that, I might say, "What do your friends call you?" And then if they tell you that, you can then ask permission for you to call them that as well. But it's surprising how many people aren't known by the name that's on their name tag. I'm going to talk a bit about a lived-in imagination technique to elicit, again, some subconscious responses, especially during painful procedures. And although you may not be doing particularly painful procedures, even putting a blood pressure cuff on, some people say, this is really tight, I'm really sorry, it might hurt. Whereas you might say, we're just going to check your blood pressure so we can keep you safe and get you as comfortable as possible for later on, is that okay? And so on. And we're going to talk about, sometimes patients are in so much pain or they're so anxious they can't actually even talk verbally. And one of the useful things you can do is what we call setting up idiomotor finger signals. And I often ask a patient, would it be okay if I just talk to you with your fingers, because I know that at the moment it's really difficult for you to talk. And they usually nod, just give me a nod if that's okay. I'm just going to call this index finger of the hand the yes finger. I'm going to call the middle finger the no finger. And what I'd like you to do is just to imagine the word yes and just allow that yes finger to lift up and let me know when you're imagining the word yes. And the finger just sort of goes up a little bit and you say, thank you, that's great. And when you're imagining the word no, just allow the no finger to lift up and let me know. And you're calling it allow the no finger, which encourages a subconscious response. You're not asking them to lift the finger consciously. You're saying just allow the finger to lift up and let me know. And we're calling it the finger rather than your finger to dissociate it from the body and encourage these finger responses to be subconscious. And then you can ask questions that the conscious may not even be aware of that really can give some interesting results. As you breathe out, as you feel more and more relaxed, more and more comfortable as you breathe out, the yes finger can just lift up and let me know when you're feeling as comfortable and relaxed as you can be for just now, when you're ready. And that can happen subconsciously. Now, often the term psychosomatic is considered quite derogatory when we talk about symptoms like pain, oh, it's just psychosomatic or whatever. But what's fascinating is every symptom, whether it's from a broken leg, brain tumour, fibromyalgia, irritable bowel, will have a psychological component and it will have a somatic component. What I'm trying to get across here is that there is no word that encompasses the psychological and the biological effects that we see in the everyday world. In the same way, when we examine light, it can be, we use a metaphor as light as a particle, photons, and light as a wave, because we haven't got, in the real world, we don't have a metaphor that describes all the effects we see in the world. So we separate out the effects when the reality is light is both particle and wave. in the same way, every symptom, including pain, is both psychological and somatic, no matter what the symptom is, to some degree, to variable degrees. But there's no word, there's no way of actually describing the effects that we see in just one word. So we have to divide up generally the psychological and the biological to investigate it and research it, when in fact the reality is the two is one, if you like. It's a single entity, very much like light is a single entity. It's neither photon nor wave, it's both. But we can't describe the effects as both. We have to separate them to understand them. Hope that's not too confusing. So I'm just sort of roughly go through the latest definition. As you say, it's an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So pain by definition, always unpleasant, is a negative suggestion. And if you're introducing it to someone who isn't experienced pain, or talking about it repeatedly to someone that is in pain, it reinforces the pain and anxiety. It's a personal subjective experience, so it's very much a description of the internal world in terms of meaning. I often see needle-phobic patients who describe a 24-gauge tiny neonatal cannula as a harpoon or a molten sword piercing my skin, or a horse needle. Now, obviously, there is a reality there that isn't a horse needle, but to the person, that is real. And how do we change that metaphor? And the way to communicate in that way is to actually investigate the metaphor the person's using in chronic pain or whatever, and actually talk to them in the metaphor. And how can we then adapt that metaphor to something that can be more helpful to them in the way they're managing and doing things? Pain and nociception are different. Yeah, nociception is the idea of a potentially painful stimulus. You can have nociception without pain. You can also have pain without nociception. So chronic pain is an example of pain without nociception, and surgery under hypnosis is an example of nociception without pain. Every report of a symptom must be recognised and validated as real before you can move on from there and actually change it in a way that might be therapeutic. And all these symptoms that may be unhelpful are actually, at some point in the person's life, had a useful role for them. And so they're adaptive and have actually allowed the person to survive a particular experience. So it's very important to realise that pain has a benefit. And, you know, obviously when we're injured, we want to withdraw from the stimulus that's doing the injury. So people who don't get pain are very vulnerable and don't live very long often. So pain has a purpose in everyday life, but also when people are getting pain without the stimulus, the meaning of the pain is really critical to actually changing it. And engaging with the meaning of the pain is really important. And we'll talk about how we can do that. Okay, just gonna. So, Graham Wicks, who you see there, he was a GP physician, worked at Women's and Children's as a hypnotherapist for many years, and he taught me. And I'm just going to introduce you to him as he describes what he thinks hypnosis is. But before I do, I'm just going to show you how we're all in a hypnotic state most of the time. While I've been talking, you've been in and out of a hypnotic state, daydreaming, when's he going to finish, looking forward to morning tea, when's the next speaker coming on, and so on. So we're all tuning out, maybe even having out-of-body experiences, as I say, daydreaming or whatever. And there's an experiment done in the States that really showed how we really are in a hypnotic state. And it may be 300 or 400 times a day for a few seconds, we're in a hypnotic state. When you drive home, if you just recently moved house, you often drive to your old home rather than your new home. Because the brain makes its best guess of where you want to go. But if you actually instruct it to say, I'm going to drive to my new home, it won't make that mistake. It drives to the new home. But it's primordial process thinking, it's primitive process thinking, it makes a guess to help you, and you subconsciously then just drive to the old home. And you're in hypnosis when you do it. It's a conscious state.
Seems obvious. Their faces are different, their hair is different, even their shirts are a different colour. And yet an experiment by psychologists Dan Simons and Chris Chabris at Harvard reveals that our brains actually process very little of what comes in through the eyes.
In this experiment, a subject comes up to a counter and a first experimenter hands them a consent form. As soon as they finish signing the consent form, they hand it back to the first experimenter, who then takes the consent form, ducks down behind the counter to put it away, and a different experimenter then stands up and hands the subject a packet of information and sends them into a hallway where we ask them questions about it.
This wonderful experiment, incredibly, in 75% of cases, the subjects don't notice a thing.
The lady who took me up here, she opened the door for me and told me to walk over to the desk.
This form.
All right. I think there was a sign that said experiment.
Mm-hmm.
And a man there gave me a form to sign.
Mm-hmm.
There was the guy standing under a big sign that said experiment. Mm-hmm. And to my left, there was like a pot with some dirt in it and some plastic containers. Is it the fifth?
Yes.
Oh, I filled out a form.
Okay.
Right.
This form.
Anything unusual at all after you signed the consent form?
No.
This is only gonna take 5 or 10 minutes.
Yeah, it'll be real short.
Okay.
The person who stood up was actually a different person.
Okay.
I gather you didn't notice that that was different?
No.
A different person actually stood up and handed you this form and sent you out toward me. I gather from your reaction you didn't notice that?
No.
Okay. Don't feel bad about that. Actually, most of the time, we find about 75% of people.
I have a working definition of hypnosis. It's a simple one, but it explains a lot about hypnosis. And hypnosis is many things, but one thing it always is, it is an altered state of consciousness in which sensory input is processed in a different way, which means a different way from the way we normally process. What is the difference? Well, the main difference is that the mind in hypnosis tends to drop its critical, logical faculties and become far more accepting of what you tell it. And it's a state of heightened response to suggestion. And it is often a state of relaxation, but it doesn't have to be. And there are many instances in everyday life of hypnosis occurring in an active state. For example, marathon runners go into a state which is really hypnosis, where they become focused and they go through what they call the pain barrier, so that they tend to be able to not so much block out the pain and the discomfort, but dissociate from it. And that is another phenomenon of hypnosis, dissociation, which is the ability to separate yourself, if you like, separate the experiencing ego from the observing ego. So I'm going to show you a very interesting case of surgery under hypnosis. And the patient says afterwards, when asked, what did that feel like? She said, oh, I knew what they were doing all the time, but it didn't bother me. It was far away from me. So she really had a painless pain.
Okay. So one of the things, often patients will come in saying they've tried everything and they don't, they can't imagine there's anything else that they could possibly do. And quite a useful metaphor is to use an example of, I often would ask a patient, well, look, if I ask myself to dilate the blood vessels of my face, this is a conscious command and the blood vessels just will not respond. They don't understand conscious commands. It's an autonomic part of the nervous system. But if I imagine myself in an embarrassing situation, often the blood vessels will dilate and we get a blush. Similarly, if I tell my salivary glands to secrete, they're not going to do it, again, conscious command. But if I imagine sucking on a lemon, eating a favourite food, chicken curry, and I can always feel my salivary glands secreting as I'm talking to you, yes, you can elicit and get a response. And as a metaphor for the patient, once you know the language, you can actually do things you couldn't imagine doing previously. Most of our functioning, most of our interactions are subconscious. And people talk about this all the time, being in two minds about something, conscious, subconscious, being besides oneself. Out-of-body experiences, daydreaming, tuning out. They're all everyday examples of the conscious-subconscious divide, which is just fluctuating all the time in our daily activities. When we actually think about communication, obviously we're often talking in ways that indicate how we're perceiving the world. I'm not looking forward to my surgery, for example, or I'm not looking forward to this procedure. Visual language, I hear what you say, auditory language. I feel like I've got a weight on my shoulders, kinesthetic language. And often if we engage with patients using the language they're using, you may not be looking forward to your surgery. Perhaps you can see yourself recovering a bit quicker and more comfortably than you thought you might do. So again, visual, when you're engaging with people will actually be much more meaningful and will enhance the suggestion that you're actually giving when you engage in their own perceptions. Superficially, or consciously, this is what we think communication is, exchanging information and meaning. There's a lot of other aspects to it. And the one I'm going to be talking largely about, obviously, today is the subliminal aspects of communication. But it's also a primary way of gaining rapport. And rapport is critical in any interaction. Trust and rapport is really critical. And although a lot of the language, especially in hospitals, frightens patients and is actually harming them, equally it can be used to soothe and comfort them and help them relax in lots of different ways. Now, when we see patients, and certainly in hospitals, they're feeling helpless and dependent, there's a loss of control. Often people end up being very passive, regress to childhood states. They're just, the incomprehensible technology brings they're flitting their conscious awareness from the outside, and it's like rabbit in headlights. They start focusing internally and become very vulnerable to suggestion, both positive and negative. So when you're seeing an anxious patient or client, they're actually very vulnerable to suggestions, and it's good to know how you can provide helpful suggestions rather than negative suggestions. So as an anaesthetist, we're focused on safety and comfort, but we don't really think about giving patients control or choices, whereas patients often, one of the biggest things in a healthcare environment is just feeling out of control with their symptoms, with the disease or whatever. and the lack of choice they often have in that situation, how it can give patients choices where normally there don't seem to be any. Just a simple example, I deal with a lot of children, and even just asking them, when you climb onto the bed, would you like to hold mummy's left hand or mummy's right hand? If they actually choose a hand, what else have they told you? They're going to lie still on the bed. So you can actually suggest something and give them a choice, and if they actually accept that suggestion, they will subconsciously lie still. Comfort, surprisingly, is relatively low priority. For some patients, it's extremely important, but much more important tends to be this sense of control and having a choice in their care. Now, there's a sort of metaphor, this cricket game here at the Oval, and what the metaphor is, so often patients are the field of play where therapists do things to them, especially doctors, putting lines in, drips, epidurals, whatever. And, but rather than the field of play in the hypnotic model, they're actually part of the team. In their own healthcare, they're a player with full rights as any other healthcare provider, and they're really very much part of the team in their own healthcare and actually showing them the skills they can use to facilitate their own recovery over what they're experiencing. So when we're actually looking at medication, this type of hypnotic communication, building rapport, facilitating cooperation, you can actually provide analgesia with this hypnotic communication in the same way that medications can, anxiolysis, very easy to administer, rapid onset. A hypnotic suggestion can work in seconds, which is really surprising. Minimal side effects. One of the things that medication cannot do is empower the patient. Whereas if you teach them skills that they can use within their own care, that's incredibly empowering for people. This is just an example of a metaphor we use in pregnancy for labour, where we explain to women they're like an Olympic athlete aiming for a gold medal. They don't know whether they're in for a sprint or a marathon, but every system in their body during pregnancy is working towards allowing them to give birth as safely and comfortably as possible for them and their baby. And then you can go through all the physiological changes that happen in pregnancy that's going to allow that to be achieved. Now, when we see, I actually manage a lot of burns patients, and when we see burns patients in theatre or prior to theatre, they're in situations where they're really overwhelmed by the experience and, again, very vulnerable to suggestion. They get this internal absorption I've been talking about, very little reality testing, which in children happens anyway, but in extreme stress, this happens with adults as well. And patients will frequently respond subconsciously as they become highly suggestible. Now, if you give a negative suggestion in that situation, it can be really harming them. And so how do we give suggestions that are helpful is one of the things I'm going to be going through, hopefully. So great, just talking to you about these two underlying language structures that I alluded to at the beginning of the talk. Great. This is the deconstruction of any interaction. So we start with the greeting, rapport building, and the rapport building actually utilizes the second acronym laws. Assessing expectations so that are we all on the same page as the health staff and the patient, the client, on exactly the same page in terms of their expectations and goal settings that we are. Addressing any concerns. And at the end of an interaction, there's always a tacit agreement. I'm going to see you in theatre in an hour, or I'll see you next week, or we've we've dealt with the problem. If there's any issues, you can just let me know in the future. So at the end, there's this tacit agreement. It can be it can be formalised as a consent form if they're going for a procedure, but often it isn't. Often it's just, well, where do we go from this point to the next point in the patient's recovery? So this rapport building and also way of eliciting therapeutic subconscious responses is a Law's approach, where listening, acceptance isn't accepting, it's accepting where the patient is, where the client is. It's not accepting that what the patient's telling you is real from your perspective. It's not agreeing with something that obviously you don't necessarily agree with, but it is accepting the patient's reality. So for example, if someone tells me with tattoos and body piercings they're needle phobic and this cannula's the horse needle, I'll say to them, well, of course you think it's a horse needle, you're needle phobic. Lots of needle phobics have these images, so it's perfectly natural for you to think that with the situation you find yourself in. And the same with chronic pain. Actually validating the experience as real for the patient without necessarily buying into the experience as an external reality, if you like, is really important in getting that trust and then moving on to something therapeutic. I don't know whether you've heard of Erickson, but a key part of Ericksonian hypnosis, he was a psychiatrist, a very famous hypnotherapist who key thing was utilising. Often when patients bring you a problem, it's actually the solution. They're bringing you the solution embedded in the problem and how they describe the problem. And it can always be utilised, sometimes reframed and sometimes modified through suggestion. So just running through again, these are the key things we're going to talk about. Of the subconscious communication model. So I'm just going to first, so you all know this. You want to hear what's said. Did you hear the words correctly? What type of words is the person using? What's the patient meaning in what they're saying to you by the use of the words they're using? Do they know they've been heard? And do they know they've been understood? Now, we can never fully understand another person. We're not them. We've never lived their life experiences. So we have to recognise that it's actually far more empathic to say to someone, I can't possibly understand what you're going through. I realise that. But what I do understand is seeing many patients in your situation, how we can manage this in an effective way for you. And I wonder if it would be okay for us to help you. So what are these 75 essential steps I want you to take away from this talk? Here they are. Okay, so this really is the crux. There's so many patients that feel they've never been listened to. And just validating and really listening and really validating what they're telling you is real, no matter how crazy it seems, is really important. And that's a critical aspect of all this. So we all have our own reality. In healthcare, we have probably a more common reality than a lot of the patients we see. The second reality is the person we're interacting with will have a very different reality from our own reality. And it's really helpful to recognise that. Now, the problem with any interaction is that all the solutions are bound in these two realities. Now, and that's when therapists think they've tried everything and there doesn't seem to be a solution to this problem. But in fact, there is a third reality. Billion realities on the planet, and realise there's in fact thousands, hundreds of thousands of other solutions you're never going to be exposed to. Now, what's interesting about that is as you recognize that, 3 or 4 things come into your mind subconsciously of possible solutions. And I remember a chronic pain 16-year-old who parents had sold their house to pay for a treatment, and she'd had terrible experiences, seen multiple psychologists, multiple psychiatrists for her chronic pain. But what I noticed when I went to the third reality, it occurred to me she'd arrived at her appointment on time. So this was an amazing thing for someone in pain, the hurdles that patients go through to get to their appointments, and not only to get to their appointments, to actually get to them on time. She was breathing normally. So I just said to her, I'm amazed how you've overcome all these difficulties you've had and got to this appointment. I'm amazed at that. I'm amazed you've actually got here on time. And I notice how regular and powerful your breathing is. And I'm noticing now how you're breathing. Every time you breathe in, you can actually start finding yourself breathing in a bit of strength and control you didn't even know you had. As you breathe out, you can start blowing away some of the unhelpful things into the room that have been stopping you doing stuff that you want to do, so that every time you breathe in some strength and control. Every time you breathe out, you just start blowing away the unhelpful stuff, unwanted thoughts, unwanted worries, unwanted perceptions. That's right. Well done. That's good. Aha. Okay. Okay. So we've talked about this, so I'm not going to spend time on it. Often in healthcare, if you can imagine the brain's like a taxi, you're getting into the taxi, you're telling the taxi driver, I don't want to go to the CBD, I don't want to go to the harbour, I don't want to go to the hills. And the taxi driver's going to get really confused, like, well, where do you want to go? And often people are constantly talking about patients in terms of where they don't want to go. We're going to give you something to stop feeling sick. Don't panic. There's nothing to worry about. There's no need to feel anxious. We're going to give you some pain killers, and so on. Let me know when you have pain rather than let me know when things start to feel more comfortable. Rather than this is going to sting, we're going to just numb the skin and allow us to finish more comfortably than otherwise. This may hurt. You may or may not feel something. So again, and if you always revert to meaning when we do anything with patients, if we describe why we're doing it rather than our expectation of a perception, particularly in a negative way, it's far more helpful. So changing our communication to the purpose and meaning rather than trying to predict a perception can be helpful. These are just everyday examples. Bee sting coming, yeah, we talked about that. Even if you say this won't hurt, patients are hearing the word hurt. Subconsciously, we don't hear the not. I've just talked about that. I'm just going to move on. Rather than there's nothing to worry about, explain how we're here to help and what we're going to do about that, and so on. The worst part, most people find that things are a little easier than they thought they might be. It's often more helpful. Anyway, I'm going to move on. So when we think about suggestions, when patients are in extreme anxiety, they're already in a hypnotic state, also in extreme pain, you can be very direct with them and you can say, when you breathe in, you can start feeling stronger and more in control. And when you breathe out, you can start feeling more and more relaxed. Now, an indirect example of that suggestion will be most people find when they breathe in, they start feeling more in control of what's happening. And most people find as they breathe out that they can start feeling a little bit easier in themselves, a little bit more comfortable, a little bit more relaxed. When you're talking about other people, that's indirectly saying to the patient, you can do this too. And it's a lot less threatening than you. We've talked about yes sets, we've talked about truisms, we've talked a bit about pacing, the functional residual capacity. The you know you can do this is not a conscious knowing. There's two types of knowing that when we talk to patients. When I'm talking to patients who are extremely stressed and giving them a suggestion, I will often say, you know you can do this. They don't know consciously they can do it. But subconsciously, you're telling them they know that you can do this. That's a subconscious knowing. Even though you don't know you can do it yet, conscious knowing. It sounds a bit weird. If you tell someone you don't have to relax, you're actually telling them subconsciously you have to relax. But by saying you don't have to relax, it removes conscious effort so that they can actually engage with the suggestion. If patients say to me, I can't relax, I'll often ask them to try not relaxing then, and it'll just seem to happen on its own without you thinking about it. There's nothing you need to try, there's nothing you need to think about, it's just going to seem to happen all on its own. Now, when you say to someone, try not to relax, when they ask you that question, it does a couple of things. It's a confusional statement, it's quite unexpected, it's a surprise. It tends to flip people into a subconscious frame where they're more likely to accept a suggestion. When you use the word try's a failure word. So consciously, they're going to fail not to relax. But subconsciously, they don't hear the not. All they hear is the relax. You might have to go away and think about that one. Anyway, so these are the things that increase hypnotizability in the population: extreme stress, pregnancy, children. And I'm not really going into too much more apart from saying that there's a lot of research around placebo and nocebo responses. And just as an example, red pills tend to wake people up. If you've got writing on the tablet, it makes it more effective. If it's scored, it makes it more effective. 4 tablets are more powerful than 1 tablet. And expensive tablets are more powerful than cheap tablets. And injections are more powerful than tablets. So there's a whole load of subconscious things going on when we're giving medication and creating these interactions. And this article that we wrote some years ago on the implication of nocebo will explain a lot more of this stuff to you. Anyway, this is my sister-in-law. I was giving a talk and we were just in Sydney, Chinatown, and she was telling me about the birth of her first child.
My second child had to be delivered through cesarean, and the anaesthetist said to me, oh, just bend over, it won't hurt. No, yes it will. Your backside's going to feel like it's going to explode. So I was ready for, incredible pain that was going to come in, and it was horrible. My backside did explode. Yes.
Happened here was the anaesthetist gave her a suggestion when she was incredibly vulnerable of her backside exploding, and that ended up being the experience she had when she had her epidural. So this is just a really good example, and that experience was with her for over 20 years. So these throwaway lines inadvertently in an attempt to be helpful can often have long-lasting effects. And there's a whole series of conditions where these non-biological effects can come into play. And I haven't got time to go through all this stuff, obviously. So these are real effects. You can image them in the brain. They're neurobiological, even though we considered them non-biological. They are real and can be measured and can be viewed. This is Darren, one of our orderlies. He agreed to go into a hypnosis experiment where I asked him to imagine an anaesthetic glove. He let me put a needle in, and then he described the experience. Which is good. The eyes are getting really heavy, so heavy you can't keep them open. And you can just rest your hand there on your lap, Darren, that's really good. You can just rest your hand on your lap, that's really good. Excellent. Okay. And I just want you to know... There we go. feeling nicely relaxed and comfortable, awake, alert, refreshed.
The hand felt like pins and needles from here down.
Right.
And like really numb. When you talked about that glove,
yes,
the anaesthetic glove going on, it felt really tingly sort of thing. But
right.
It felt sharp, but no pain.
Right. So this is really an example of sensory cortex staying unchanged, but anterior cingulate being inhibited with the suggestion of arm anaesthesia using an anaesthetic glove. And this is a classic experiment, 140 women having epidurals and spinals in a hospital in Boston, where the standard language was bee sting coming as they were injecting local. And they randomized 70 women to have the standard language and 70 women to be told it was numbing the skin to allow them to finish the procedure more comfortably than otherwise.
I had surgery recently, and I had been to a talk given by Alan on hypnosis and suggestions with procedures. So I was a bit prepared for the language that might be used around some of the things that would be done during my stay in hospital. And part of the things I had done would have Clexane injections daily. And somebody had warned me that they would sting. The first injection, the nurse came in and said, "I'm sorry, but this stings a bit," and the injection certainly did. And the next day I was busy on the phone when the nurse came in. She said nothing and just put the injection into my leg, and I actually didn't feel anything at all. And the third day, the nurse came in and said, "This really stings." And when she said it really stings, that injection actually hurt more than any of them. I just thought it was interesting that I was prepared to hear that language and hoping that it wouldn't sting, but it did.
So how can we protect patients from, we can't change the world, the outside world, but how can we protect patients? Well, you can talk to them about any negative suggestion you hear, anything unhelpful that you hear can be like a barking dog tied to a tree that you can just walk past. Or it can be like an untuned television set. Or it can be like swatting a fly. Or it can be like missing a catch and letting the ball just go behind you. Or it can be like someone speaking to you in a foreign language. Or just turning the volume down till you can't hear it. Or having a semi-permeable membrane around you so that only helpful suggestions can be retained in your body and anything unhelpful will just go through back out to the outside world where it can't re-penetrate the semi-permeable membrane back into your body. So you're only going to receive helpful things that will be there for you when you need them. They're the sort of things you can actually do to protect patients from the ravages of hospital treatment. I'm just going to move on a little bit because I just want to show you a few videos of this sort of stuff being done in practice, and then we'll call it a day. I'll just give you a very quick I'm going to give you a very quick example. A very quick example of how laws can be used to give a very rapid response. I had a patient who was asking for an epidural in labour, and I came into the room and she started swearing at me as I was talking my usual hypnotic language, and she was screaming at me, "I can't listen to you, I can't listen to you, I can't listen to you, I'm in too much pain." And I said to her, "I know you can't listen to me, so I've listened and I've accepted using her words. In a moment, you're going to find you can hear everything you need to allow yourself to start feeling more comfortable so you can sit still while we finish the epidural and to help you feel comfortable. And every time you breathe in, you can breathe in some strength and control you didn't even know you had. Every time you breathe out, you can start blowing away some of that discomfort into the room. There's nothing you need to try and do. There's nothing you need to think about. It'll just seem to happen all on its own." And within 2 or 3 minutes, she was just sitting curled up and experienced the epidural very comfortably. So listening, acceptance, utilising the fact she can't listen, reframing it to hearing, which is a passive thing she doesn't have to consciously do, and allowing her to hear words that will be therapeutic suggestions to help her through that experience. I'm just going to finish with this child here, just as another example. She was having burns dressings on the ward for an infected burns. I'd actually anaesthetised her 40 times before, and anyway, they were taking 2 hours to do the dressing changes. And what I did was I asked her to, and she needed three a day. And what I did was I asked her what she wanted to do when she left hospital, and she said, I'm looking forward to seeing my baby brother. Now, her mother was 36 weeks pregnant at the time. And I said, did you know that by having these dressing changes and cleaning the skin so that it can heal more quickly, he'll be able to go home sooner so that you can see your baby brother? And she said, no, I didn't know that. And I says, well, as you have your breathing, knowing that you're going to go home sooner to see your baby brother, isn't it interesting that you might be able to have your dressing changes a lot more comfortable than they were previously? Would that be okay for that to happen? And she said, yes, that would be good. The next dressing change took 10 minutes and the one after took 5 minutes. And within 10 days, all these infections had been healed. Tell me about it. I'm just going to finish there, I think, because I'm running out of time. So, just a couple of ideas about talking about pain in maybe other modalities, the shape, the sound, the colour. And then just finishing off, I haven't got time for that, but that's okay.
He was sick.
And I'm just going to say, the ABCs that I really want you to take away is appreciate that most communication is subconscious, beware of the nocebo effect of our interactions, and how important that choice and control is for patients in these situations and how empowering that can be. And I'm just saying thank you for your conscious and subconscious attention. And